Good afternoon to everybody. My name is Santiago Martínez. I'm a thoracic radiology with St. Luke's Hospital in Kansas City, affiliated with the University of Missouri in Kansas City. And I'm here today, by the way, today is June 25, 2020, to talk about imaging findings on COVID-19. And the reason why I'm giving you the date is because this is a highly fluid topic that changes a lot. And this actually is a summarized version of my original talk on COVID-19. And every time I have given this talk, I have to tell you, there has been new changes, and this is not the exception. So please be considerate in the sense that I am talking on June 25th, 2020. So my goals for the next, hopefully, 15 or 20 minutes are to review the imaging features of pulmonary involvement with COVID-19. I'm going to discuss the implications of radiology in treatment. And very briefly, won't be something long. I'm not a clinician, so my intention is not to really talk a lot about treatment, but I do want to talk about some imaging features that are pertaining to treatment. And I also want to try to highlight the importance of multidisciplinary work. Thoracic imagers are pioneers on multidisciplinary work, particularly in the area of interstitial lung disease. And I think this approach has been incredibly useful, at least for me and for my group of clinicians in the hospital where I work for. So hopefully I will share with you that as well. I'm not really going to talk a lot about the specifics about coronavirus. Coronavirus are a very common virus. We see every day pneumonia secondary to coronavirus. There's nothing new about this. 2 to 3% of all community-acquired pneumonias are secondary to coronavirus. COVID just happens to be one particular type of coronavirus, and of course, it's the cause of the pandemic that we're seeing right now. But coronavirus are the fourth most common viral pneumonia after influenza, metapneumovirus, and parainfluenza. So by all means, this is a very common disease in the clinical practice. Obviously, I'm not going to be talking about all the coronavirus. I'm just going to be specifically talking about COVID-19 and all the particulars about this. This probably is the slide where I'm going to spend more time, and I'm going to ask you to bear with me, because if we understand this, we will understand the imaging characteristics of the pulmonary involvement with COVID-19. So let me just briefly explain. So this is the progression over time, okay? Initially, we have an infection. I mean, this is clearly an infection. I mean, there is pathologic evidence that is an infection. But it's not only an infection, there is also an inflammatory response that will develop soon after the infection is going on. And they actually overlap. And you guys, and in general, people probably heard in the news, or we're physicians, in our groups, about the cytokine storm and all this terminology that people have been using. Well, that cytokine storm is no other than just an inflammatory response. And that inflammatory response eventually will either kill the patient or will resolved and the patient will survive. And when patients survive, there are a few options that will happen. One is the patient will develop fibrosis, and I'm going to show you some images of that later down. Or the patient is going to have a resolution of the symptoms. Now, how this progression will translate into the clinical presentation and the radiology presentation. So initially, the patients with infection will be either asymptomatic. I think we've heard enough in the news that there are many carriers of the disease that will not have any symptoms. And that's part of the problem of the pandemic, is that you can be infected by someone that actually doesn't have any symptoms. Patients can also have mild symptoms, and we're not expecting to see those patients in-house. Those patients usually will stay home or will not even go to the ER, or if they go to the ER, they will be discharged. Now, once the inflammatory response kick in, you're going to see more severe symptoms. Some patients will not have symptoms and they will just resolve the disease, but other patients will have more severe symptoms. Many of them will require hospitalization. And they may require hospitalization because they're not able to oxygenate blood properly. So they might require oxygen by cannula, for example, or in the worst cases, or later down in the disease, they will require to be intubated. But most of the times, the rule is this particular phase of the disease, the patient will typically not be intubated. Now, the patient might progress to a more severe picture, and usually that we call that acute respiratory distress syndrome. And those patients will require intensive care unit, and most of them will require intubation. And once we're here, that's a very bad prognosis. Now, what are we going to see on imaging? So again, very early in the disease, we might not see anything, or we might see some opacities that are non-specific. Sometimes if we go into CTs and detail imaging, we might see patterns of organized pneumonia, and I'm going to talk about that a little bit better when I show you the cases. You might see the same findings also in patients who have severe disease that are hospitalized but not intubated. And once the patient progresses to ARDS, then he will develop findings of ARDS. We all know what are those findings. It's basically a non-cardiogenic pulmonary edema. If you guys remember the Berlin criteria for acute respiratory distress syndrome, one of the criteria is opacities involving the 4 quadrants of the lungs. So that's, it's a pretty non-specific finding, which will be equal or common for every single disease that results in acute respiratory distress syndrome. Now, if patients survive, and that's where the money is at this point, is what's going to happen with those patients that survive. What we've seen, and I'll show you some images, is that they will develop some sort of fibrosis. And that fibrosis has a specific pattern, which it's interesting, but it's concerning because not only this is a deadly disease, but it's also a disease that will create scarring of the lungs and sequela from the patients if they survive. So this is really, really important to understand the disease, and it's really, really important to understand what I'm going to show you regarding the imaging. This is the first case I'm going to show you. It's what I would call the prototypical case of COVID-19 involvement of the lungs. So what are you seeing here? You're seeing an abnormal radiograph, but if you see these opacities are fairly peripheral and bilateral. They're not central, they're peripheral, which, by the way, this is not what we see in acute respiratory distress syndrome. What we see in acute respiratory distress syndrome, and I'll show you a case later down, is more diffuse opacities. Now, I'm going to be showing you some information because I want to highlight the importance for the radiologist and for the clinician to know about these things. Number one, obviously, we need to test patients for COVID, and that is important. We know that there are some false negative studies, but nevertheless, we need to prove that it's COVID. One important feature that I encourage you to always check is procalcitonin. Procalcitonians are usually normal or mildly elevated in viral diseases, and they tend to be really very elevated in bacterial diseases. So if you have a patient who has an elevated procalcitonin, that patient might not have COVID, or might have COVID plus something else, but most likely will have a bacterial pneumonia. So I think for me, the interpretation of images is really critical, and I never stop looking the procalcitonin because it gives me a lot of information. Ferritin, you're going to be hearing me talking about this. Ferritin is an inflammatory marker, and in many inflammatory states, ferritin will be elevated. Now, particularly in COVID, what we've seen is that the higher the ferritin is, the more chances the patient will get complicated. And I'm not going to go into this, but for whoever wants to get more information in this, I think it's a fascinating topic. The ferritins could get to a level of thousands. And when that happens, the patients behave like something that is known as hemophagocytic syndrome. Now, I'm not saying every single patient with COVID will develop that. I'm just saying that some patients who have a skyrocket ferritins will behave like a hemophagocytic syndrome. And I think it is important to understand that, because it tell us that this is about the inflammation and not so much about the infection, which is a common topic in my talk. C-reactive proteins tends to be elevated as well. So again, this is the prototypical case: peripheral opacities, not central opacities. And this patient happened to have a CT. We don't do CTs in a lot of patients, but in this patient, they wanted to rule out a PE, which the patient didn't have. But what I want to show you here is that these opacities are very, very specific. I mean, they're so plural. There is a very, very well demarcated region that separates the abnormal lung from the normal lung, which is something that we don't see in pneumonia. It's something that we see in other processes like organizing pneumonia. This patient also has, for example, areas of a spare lung, like this area here, for example, or this other area here, or this other area here that we call perilobular pattern, which is a feature of organizing pneumonia. So, you know, this presentation that looks like an organizing pneumonia is the prototypical thing that we're seeing in patients with COVID, understanding that these are patients that are not yet in the ICU, patients that are not yet to the point of developing acute respiratory distress. Now, why this is important? This is important because when you look the autopsies of patients with COVID, pathologists are telling us that patients are dying with diffuse alveolar damage, which is the histologic correlation of acute respiratory distress syndrome. Now, that information, I don't have any reason to doubt that what pathologists are telling us is true. But when the patient is midway in the inflammatory phase, when the patient is initially sick, the pattern that that patient will have is non-ARDS. He eventually will develop ARDS, but at that point, the intermediate phase, that's not yet ARDS. Now, this is a very interesting paper. It's obviously a few patients only, but I think it tells a lot of information about this, which we need to recognize. These are a few patients who have lung cancer who were taken to the OR for removal, and incidentally, they find out that these patients have COVID. And what they found in those patients, again, these are patients that are not in the ICU, they're not intubated, they're just at the beginning of the disease. Some of them are asymptomatic. I mean, they just take them to the OR to remove the lung cancer. And what they found in these patients is a pattern of organizing pneumonia. So that correlates with what we're seeing on imaging. And I want to go one step further, and that's one of the reasons why I said what the date is today. Last week, there was a paper, not a paper, but a statement from the University of Oxford in which they found in a study that the use of steroids will decrease mortality by 1/3. This is not a published paper yet, but it's a statement. And if we talk to people in the United Kingdom, we talk to people in Spain and in Italy, many of them are using steroids. Now, majority of the places in the United States are not using steroids because the World Health Organization and the CDC guidelines do not actually recommend the use of steroids. And I'm not gonna go into the discussion of why is that, but my point and what I wanna make as a teaching point here is, if the patient has this pattern that I'm just showing you, there is some correlation showing that those patients might have a pattern of organizing pneumonia. Now, that pattern might be a specific type of organizing pneumonia, which we call acute fibrinous organizing pneumonia, which is a specific type of organizing pneumonia, but we don't have time to go into that. But just in case you want to check into that, I think this is a wonderful paper to see that. Here's another case. This is a patient who is completely asymptomatic. Patient has this opacity, ground glass, but what I want to highlight here is there is more denser area here peripherally. You can see here that this is ground glass, but there's an area that it's a little bit more denser. This in thoracic radiology, we call the reversed halo sign. The reverse halo sign is a non-specific finding, like many other findings in chest imaging, but it is a finding that very frequently we see in patients with organizing pneumonia. So again, this is just another example of what we're seeing in that intermediate phase. Again, these are not patients that are intubated yet. These are not patients in the ICU. Is such of organizing pneumonia. And the other pattern that you'll see is this. This is the patient. You can see this patient is already intubated. He's already in the ICU, and the patient has completely diffuse opacities. And I'm just showing you the progression over a few days, showing diffuse opacity to worsening opacities. Now, pay attention to this because this is really interesting. This is a COVID-19 positive patient. The ferritin in this patient is in the 1,000. It is in the range almost of hematophagocytic syndrome. As I said, some of these patients might be in such bad shape that they behave like a hematophagocytic syndrome. C-reactive protein is 245, pretty elevated. Patients often develop decreased hemoglobin. One interesting marker is triglycerides. Triglycerides in patients with bad disease tend to be skyrocketing high. In this patient, for example, it was 2,931. And at this stage of the disease, patients will frequently, as with any other acute respiratory distress syndrome, patients may go into multi-organ failure. So it's not uncommon to see patients in renal failure, in hepatic failure. This patient, for example, has pretty elevated liver enzymes. So these are things that are helpful for us to, as radiologists, to check when we're dealing with these patients. This is another case to emphasize that patients may be completely asymptomatic from the respiratory standpoint. This is a radiograph which, you know, it looks pretty normal to me. Same day, the patient has abdominal pain. They did a CT of the abdomen. This is not a CT of the chest, and you can see those opacities again, peripheral, bilateral, ground glass with some areas of perilobular pattern, which is pretty characteristic of organizing pneumonia again. These, remember, we are going to have patients who are asymptomatic, and it's not uncommon to see patients coming for a follow-up cancer patient, for example, who have these findings, and they might just have COVID-19. And if we see these features, we need to suggest that possibility, and we need to work those patients out. This case, I want to show you to remind you that unfortunately, and despite the fact that patients are scared to come to the hospitals these days because of what's happening, patients are still getting pneumonias from other origins. Patients are still getting other diseases. And part of what I'm going to show you the rest of the time that is left is those things. Now, we need to be smart about this. Not every single patient with an opacity will have COVID. We need to look for those specific findings. This is a patient, for example, who came with a clinical picture that looked like COVID. Patient has cough, has fever, etc. You can see that the radiograph is pretty abnormal, but it's not what I was showing you before. It's not those peripheral subpleural opacities. This is more like a focal disease. Patient has a CT same day. There's a clear consolidation here in the right lower lobe. But what I want to also highlight here is that patient has a lot of trim-bud opacities. One message that I want to leave today is COVID-19 does not produce central lobular nodules. I yet need to see a case in my practice in which a COVID-19 is present with central lobular nodules. Central lobular nodules is not a feature of COVID-19. So if we see that, of course, any patient with respiratory symptoms and fever needs to be checked for COVID, but if you see trim-bud nodules, the likelihood of that patient having COVID is very, very low. And this patient, again, had an increased procalcitonin. Again, if you remember what I just said, procalcitonins are not typically elevated in patients with viral diseases of viral pneumonias. For example, flu typically will not have elevated procalcitonin unless it's super infected with a staph aureus, for example, but typically will not have. And the same thing with COVID. COVID will not have an increased procalcitonin typically. This patient ended up having a mycoplasma pneumonia. And these are features that are more commonly seen in mycoplasma pneumonia. I want to spend 1 minute talking about what is coming to us. I don't feel I have enough experience at this point, but we're starting to see patients who survived, patients who have been 1 month in the ICU intubated, and now they made it. Luckily, they were lucky and they made it. And now we're starting to see, and these are two different patients. And what I want you to see is that these patients have these linear opacities that are peribronchovascular, they're bilateral. There is some volume loss, and you might see that there's some bronchial abnormalities. I think these are better seen in this other patient. You can see these bronchi are completely abnormal. There are areas of, traction bronchiectasis bilaterally with a lot of reticulation. So what we've seen so far in our patients, we're not following every single patient, we're just following some patients occasionally for something different, is that many of these patients are developing pulmonary fibrosis, and we don't know what the sequela or the consequence of this fibrosis is going to be in these patients. But I think as time goes by, we're going to have a better idea. But my concern is that patients are developing fibrosis. And I'm just going to leave a little question here. I don't know the answer to this, but my question is, if the typical involvement of COVID-19 is a pattern of organizing pneumonia, and if there are some data suggesting that steroids might decrease mortality, can steroids decrease the amount of fibrosis? I think this is a question that we're going to need to answer fast, and I hope that in a couple of months we will have some answers about this, because I think the role of steroids might not only decrease mortality, but also attenuate the degree of fibrosis. But again, this is a question that is not answered yet. Very briefly, I think I've talked about this already, showing you the cases, but important to emphasize that patients with COVID, especially those in bad shape, will develop cytopenias, which could be in the form of decreased hemoglobin or neutrophil counts. Very important to check ferritins. Initially in March and early April in my hospital, some physicians will ask for ferritins, others will not. Some will ask for for sedimentation rate, others not. Some will ask for C-reactive protein, etc. And we have get together, discuss the situation, and now all our patients are studied with the same markers. Why? Because having an skyrocket ferritin, even if the patient is not yet doing badly, it's a really important marker, and it's telling us that that patient is in the way to develop a bad complication. That patient is going to end up in the ICU. So knowing these values, it is important. We already know that the patient has COVID, but knowing this, these are markers that will help us a lot. Same thing with triglycerides. You know, they skyrocket in patients who are complicated. Again, procalcitonin tend to be decreased. If the procalcitonin is increased, you have to think about something else, some sort of bacterial pneumonia, or, which is possible, you can talk about COVID with something else, which happens. We are seeing some cases of COVID and something else. Most of these patients will have D-dimer elevated and elevated fibrin degradation products. There are some controversies out there in regards patients having an increased risk for PE. I think it is a very noisy topic, and the reason why it's noisy is because when you go to the autopsies, pathologists are telling us that these patients have microthrombosis. However, microthrombosis is an essential part of the ARDS. So when they're telling us about the microthrombosis, that doesn't necessarily mean that those patients have PE. It means that they just have ARDS. However, there are some papers suggesting that patients with COVID might have an increased risk for PE. I don't think it's a very well-known fact, but it is important for you to know. And it is one of the reasons why our patients with COVID ended up being scanned, because sometimes we want to know if they have PE because they have any particular, clinical presentation. Obviously, we talk about liver enzymes and we talk about pulse oximetry. And the pulse oximetry, I just want to share with you a little bit of this because I think it's a fascinating thing. When you talk to not only my physicians, my clinicians in the ICU, but many other people that I've talked in the world about this, they will always refer to you something that I think is fascinating. They will tell you that the patient may have really low saturation of oxygen, but the patients don't look dyspneic. They can speak in words. They're not short of breath. And this is an observation that I think is fascinating because typically when you have a low oximetry, you will be dyspneic. So somehow in these patients, they don't feel dyspneic. They don't feel short of breath. Obviously, there are exceptions to this, but I think it is important, and it's something that it's a mystery for the clinicians and for me. I'm not going to talk about treatment. When I first presented this information, people were talking about chloroquine and azithromycin like being the best thing. In my hospital, they started to use it in March and April. Nowadays, there's a lot of questions. There are a few papers talking about this. The FDA now is involved in not recommending chloroquine and azithromycin. I personally think we need more studies to know what's the reality of this. You probably have heard about the remdesivir like being a medication that might work, and we are now running trials on remdesivir, which it's one of those medications that looks really promising. I already talked to you about the steroids. There's a lot of controversies about the steroids. Why? Because there is a study back in the last coronavirus pandemic or epidemic, which was MERS, in which they use steroids and apparently the mortality is increased. And also because there are some studies in influenza in which they use steroids and increase mortality. However, as I already said, and I encourage you to look on this because I think it's an very interesting and very important point, there is this very serious study from the University of Oxford demonstrating that steroids can reduce mortality by 1/3 in patients with severe COVID and advanced COVID. So you guys are going to need to check this and see what's the future of this. I'm just telling you the perspective today, which is June 25, 2020. There's a lot of discussion about anticoagulation. We are using that in my hospital because we believe that there is an increased risk of thrombosis and PE. And one thing that I want to tell you about ventilation is prone ventilation. I think by this time, I think it's a pretty universal information, but just in case you haven't heard about this, patients do better when they're prone. And they do better if they're not intubated, and they do better if they're intubated. And it makes a huge difference for patients when they're prone. And so many of our patients are being prone in the ICU, and if they're hospitalized and still conscious and they can follow orders, many of our clinicians are asking the patients to be prone as much as possible because the ventilation is much better in that position. Now, I want to finish this talking about differential diagnosis. Why I want to talk about differential diagnosis? For two reasons. Number one, we're still going to see patients that are coming to the hospital who do not have COVID, but something else. All right, so that's important to know. And number two, because it helps me emphasizing that intermediate patient with that pattern that I'm calling organizing pneumonia is actually that. It looks like an organizing pneumonia. So some of the diagnoses are eosinophilic pneumonia, influenza, which makes things harder, and it will make things much harder during the next winter, because then we're going to have two diseases going on at the same time. Any cause of organizing pneumonia, either idiopathic or secondary to something. I included here acute fibrinous organizing pneumonia, which is just that specific histologic type of organizing pneumonia, which, as any organizing pneumonia, could be idiopathic or it could be secondary to something else. And one that I want to show you too is EVALI. And EVALI stands for e-cigarette or vaping product associated acute lung injury. It's a name that is difficult to remember. And I'll show you a few examples and you understand this better. So this is a patient with eosinophilic pneumonia. What I want you to notice is that this is very similar to the first case that I told you was prototypical for COVID-19. Again, you can see here very subpleural and peripheral opacities, both the radiograph and the CT, with areas of perilobular. Well, it turns out that eosinophilic pneumonia, and in this case, chronic eosinophilic pneumonia, this is the typical pattern. It's a pattern that looks like organizing pneumonia as well. The only difference is that you have a bunch of eosinophils, lining the airways and the alveoli. But the pathologic pattern of disease is very similar to what we're seeing in patients with COVID. Again, which at that stage is not ARDS, it is more behaving clinically and imaging-wise as an organizing pneumonia. Here's a case of a patient with influenza. Again, this patient has peripheral, it has diffuse opacities, but you can see that the opacities are a little denser in the periphery of the lungs, very similar to what we're seeing in patients with COVID. I always thought that this was influenza. I mean, this is a patient with proven influenza, H1N1. Now I'm having second thoughts of whether what we're seeing in these patients is something similar to what we're seeing in patients with COVID. In other words, if this is just an inflammatory response in the form of organizing pneumonia, which could progress to full ARDS and to full diffuse alveolar damage. This case was presented by a colleague of mine, Daniel Ocasiones, in Houston in a webinar, and I asked him to share it with me because I wanted to show you this case. When he showed this case, and it was a COVID webinar, they asked my opinion. I said, this looks absolutely slum dunk COVID-19. You know, you can see the opacities, you can see that they're peripheral, you can see that their perilobular pattern is present. Well, it turns out that they also believed that this was COVID, and they work up the patient, it was negative for COVID, which is not uncommon in patients with COVID, you know, but they ended up doing some more testing, and it turns out that the patient has in quarantine in his house, very stressed out, and he started to smoke marijuana with an e-cigarette, and he developed this EVALI, secondary to the marijuana, exposure. So remember, that if you go back a year in time from now, we were talking about the pandemic of E-Valley, you know, even the government was talking about the pandemic of E-Valley. Well, that pandemic is not gone. That pandemic is still there. Of course, we have the COVID, and COVID is taking all the attention, but patients are still developing E-Valley, and this is a pandemic in the United States and in the world, unfortunately. So we need to be prepared for those patients as well. So I want to close by saying that the typical findings that you'll see are peripheral bilateral opacities, which may or may not be symmetric. And those opacities tend to be ground glass on CT. They can have consolidations. They can exhibit the reverse halo sign and the perilobular pattern, which is very characteristic of organizing pneumonia. Now, you might have other atypical findings, like, you know, things that opacities that don't, you know, have these features that I'm talking about. You need to understand, I think it's very important to understand that the patient will start like an infection, will mount an inflammatory response, which will cause pulmonary opacities. The pulmonary opacities are partially related to the cytopathic effect of the virus and hugely related to the inflammatory process in the form of organizing pneumonia. And then eventually those patients they either improved or they will go into full ARDS. But at that intermediate stage, those patients are not yet in ARDS. They have a pathologic pattern and an imaging pattern that looks more like organizing pneumonia. And finally, remember that many of these patients, or at least the ones that we're seeing after surviving the disease and after being in the ICU for quite a while, they will develop peribronchovascular fibrosis. And we don't know what exactly this means in the long term for these patients. We don't know what's going to happen with the lung function of that patient. We don't know if this is going to have consequences long term, but that's what we're seeing, and I want you to know that as well. With that, I finish. I appreciate very much your time. I hope to see you on a future webinar. This is my email. If there's any question, please feel free to shoot me an email at your convenience. Thank you so much. Bye.